So now the hospital doesn't have to talk about discharge. The hospital can talk about, we're going to take great care of you no matter where you need to be. And it's going to become more and more, we're just going to take good care of you in your own home, because we're just going to give you one of these stickers. And if we see something starting to something brewing, we can send a nurse to your house cheaper than you laying in the hospital bed.
Yeah.
Or we can see it coming early enough that we can say, okay, go see your doctor.
James Mault is many things, all of them insanely impressive. And chances are you've never heard of him just because he's not somebody important like a YouTuber or something, but he is someone who's changing the world of medicine in important ways. They say that the first person to live to 150 is already alive right now. And if that's true, it'll be because of people like Jim Mault and the changes they're bringing to the healthcare industry. James Mault got his start as a cardiothoracic surgeon, so that's Dr. Mault to you plebes. He went on to serve as the medical director for the Health Solutions Group at Microsoft, later the senior vice president and chief medical officer at Qualcomm. He served on the boards of Bose, the American Telemedicine Association, the Consumer Technology Association, the people who run CES, various NASA organizations. He's worked with SpaceX, and along the way founded 5 different medical device companies, his latest being BioIntelliSense, where they're pioneering health monitoring systems that work along with AI to generate real-time health assessments for doctors and hospitals. And it's all done by a tiny sensor that you stick to your chest. It's super interesting stuff, and I'm honored to have gotten to meet him and spend some time with him. In fact, we got so carried away just kind of chatting about random stuff that we got cut off and had to do a second Zoom call. So thank you twice, James, for spending the time with me. I really enjoyed it. But right now, let's jump into my conversation with James Mault.
Did you go to CES?
I've never been to CES, no.
Oh my gosh.
It's like I haven't been in so long, and now it's almost like I'm a little nervous. If I ever win, it would just be too much. Like my hype has been built up too much or something.
Your head will explode.
Exactly, yeah.
But you have to go.
Okay.
And you have to come as my guest this next January.
You won't turn that down.
Yeah. And we're actually setting up a VIP event for the R360 guys.
Oh, okay.
Yeah, that you met yesterday, and Chris.
Uh-huh.
And then we have a VIP event on the healthcare side as well. So, but you gotta come, especially a tech guru like yourself.
Oh, I wouldn't call myself that. I can barely operate my phone,
but well, no, but you again,
I am in that space, I guess. Yeah.
Yeah. And you have a big following, and a lot of people. Again, I talked to my CTO this morning and told him I saw you yesterday. I'm going to be on with you today, and he's like, he's the dude.
I'm the Big Lebowski.
What did you do to how are you in the center of this whole tech conversation?
I was working at the Dallas Morning News. If you want to hear the whole story, I was an advertising copywriter there, so I wasn't like a reporter or anything, but it was just kind of a job. And then YouTube started really becoming a thing. I had a background in filmmaking and video production and stuff. Never really could get the newspaper to take it seriously, so I could kind of do that kind of thing for them. And I just started getting serious about it around 2014. I made sure and posted a video every Monday, and I've just been doing it ever since. And it didn't start off as a science communication kind of thing. It started off as just me trying to be funny and be a comedian on YouTube kind of thing. And then I did one video on the Fermi paradox that for whatever reason the algorithm liked, and it got a lot of views at the time. It was a lot of views for me. And that brought in a lot of we're going to be a problem now. That brought in a lot of subscribers that wanted to talk about science stuff. So they were asking me science questions. So I kind of leaned into it because I've always been a bit of a nerd, So, that's just, it's just kind of how it happened. It's kind of spiraled from there. I don't have any specific training in it, but like when you were saying that your CTO was all excited that you were talking to me, it's kind of like, this is why it's good for me to talk to people like you, because as my channel gets bigger and my head grows accordingly, it's good for me to talk to people who have an actual resume of doing really cool stuff that I can like lift up in some way. Cause I mean, if I've got this exposure, that I feel responsible, there's a responsibility to, you know, highlight people that are doing cool things. And
Yeah, yeah.
so here we are. Yeah.
Well, it's not about me, but we're definitely in something that's really cool,
Mhm.
that has big implications. You were at the GoBundance talk.
Yeah.
Yeah,
Back in January or whenever that
it
was,
was
early January.
December. It was before the
That was
holidays.
December. Jeez. Okay.
Yeah,
Yeah. Yeah. It was, I loved your presentation. It was great.
yeah. I have fun, and the great thing is you know it's all relatable, right? People people generally get stuff around. It's hard to ignore healthcare
Mm,
because you can't escape it. It's something's happening with your parents, or your kid is sick, or you've got health issues, or you're trying to not have health issues.
yeah.
It's all part. It's central to the human existence, and
Mm,
uh, it's so you can usually find a common denominator with almost anyone in a room, and then you just talk about things, just like whether it's flying in an airplane or driving your car, or uh, you know the change in how we shop and how we bank. All those things are now very relatable,
mhm.
and you can draw these rapid analogies for people to go, oh, I get it, that makes sense. We used to I was just on a call earlier this morning, and I'm starting to show my age. And I said, remember when you used to have to go to a travel agent to book a flight,
Yeah.
and you would get a paper ticket that had a 4-layer, this red carbon.
Uh-huh. Uh-huh.
And both of the people were on the phone looking at me going, no, I don't remember that. I'm like, well, it was in the 90s. Oh,
Yeah.
wait a
Wasn't
minute.
that long ago, really.
You were just a kid in the 90s. But yeah, I mean, it's getting to a point where, I mean, my kids have no concept of that. What do
Hmm.
you mean? You just get on your phone, you decide where you want to go, you pick the date,
Yeah.
and you buy your ticket. Uh,
There are sometimes when I think about things like that, and it's like, how did we do this before smartphones? Like, how did we do this? And it's like, oh yeah, we had travel agents. You would go and
yeah.
go to a person and they would have to make a ticket for you.
Well, even if you ignore the whole travel agent thing, think about the cost structure of a United Airlines,
Hmm.
where if there were 50 of us that wanted to book a flight in the next 5 minutes, we would call an 800 number, and they would have to pay a human being on the other side of that
Hmm.
phone
Hmm.
to talk to us, and for us to tell them, yeah, I want to go to Dallas, I need to go tomorrow, and I want to fly at noon. And so 50 tickets being booked in the same 5 minutes requires the work effort of 50 individuals.
Yeah.
And now 5,000 of us could be booking a ticket simultaneously in the same single minute. And United Airlines isn't paying a single person to book
Hmm.
that ticket and take your money, because you used to have to give them your credit card information and everything, right? That's like gone. And yet, dovetailing into healthcare, we're still paying a nurse right now because of the nurse labor shortage. The traveling nurses are being paid an average of over $4,000 per week.
I was just reading something about this, about the traveling nurses kind of filling in the gaps and how they obviously get paid more because they're, special. But yeah, sorry, keep talking. I just saw
Yeah,
something about that.
no, and it's crushing.
Mm,
The workforce obviously is contracting. Nurses in particular are, understandably burned out
yeah.
from the COVID crisis. And so hospitals, and that's not just hospitals, but nursing homes and anywhere where someone is sick enough that they need a person checking on them and monitoring them, their only option is to pay these traveling nurses, basically a staffing service.
Mm,
And because the demand is so high and the prices are just going up and up and up, and the reality is you're you can only accomplish so much with a one-to-one human interaction, what we call synchronous care, or to put it in more general terms, synchronous services, period, whether it's the travel industry or the banking industry. I mean, again, it wasn't that long ago where you had to go to a bank to deposit your paycheck,
mm.
and you'd stand in line because there were only 3 bank tellers, right? And you had to wait to go up to the bank teller and say, I'm depositing my check and I would like $100 in cash back, and you'd sign the deposit slip. Who does that now? I mean, it's this thing called direct deposit. And now, even if I get a check in the mail, I get my phone out, I take a
Yep.
picture of the check, and it gets deposited. And so healthcare is literally one of the last bastions of the old service model that's been in existence for 2,000 years in healthcare. In 2,000 years, if you were sick, you would see the doctor, and the doctor would examine you and make a diagnosis and then a treatment recommendation.
And up until about 150 years ago, just take your blood, just bloodletting.
Oh yeah, well,
Let the demons out and balance the humors, and yeah.
just
If you're going way back.
digression. Do you know that the loved and adored first president of the United States, George Washington, people don't know that, but our first president of the United States did not die of natural causes.
It was all the bloodletting.
He was assassinated.
Oh, okay. All right. Keep going.
He
It's
was
just got spicy.
Yeah. He was assassinated by his doctors.
Now, are you saying on purpose or like just from?
No.
Okay.
But you just mentioned it. The modern therapy of that era was bloodletting.
Yeah.
Literally, he had a pneumonia, and oh, we need to bleed a liter of blood, and he got worse. Oh, he needs more bloodletting. They ended up, somebody pulled up the records. They basically exsanguinated him,
Yeah.
to the tune of almost 4 liters of blood. Yeah. It's kind of sad, but the reality. But anyway,
They forgot that the blood is important. He needs some.
hey, as you heard in my talk in December, it wasn't until the mid 1800s that anyone had any clear understanding of germ theory.
Right. Yeah.
Right. And anesthesia, x-rays, all of those things only happened in the less than 150 years ago.
Mm. It's fascinating. I've covered that here and there, especially in the Victorian days, and the whole John Snow cholera outbreaks in London, figuring all that out and everything.
Well,
Anyway, that's all
oh,
interesting.
I have to tell you one other interesting story. You feel free to edit this stuff out, but it's really fun.
I love tangents. I have a whole camera for it.
At least it's interesting for party trivia. Um, a lot of people who go to medical school, get those diplomas, uh, get almost indignant when like walking up to checking in at a hotel and they say, welcome, Mr. Mault. And some of these people, not me, I'll tell you why, they go, oh, well, it's Dr. Smith. And it's like, okay, dude, you're pretty,
Yeah.
pretty
Congratulations.
impressive. Congratulations. So, but for me, it turns out that it's actually a compliment. And the history is in the Dark Ages, during the Great Plague, the physicians, the educated, anointed ones, had no interest in taking the risk of exposing themselves to patients with the plague.
Mm.
So it was actually at the time they were called barbers.
Right.
It was the barbers who actually put their lives at risk and took care of all these people dying of the plague. And at the end of the plague, after a third of the population had been killed or had died, I think it was King George or King Henry, one of the two, actually bestowed the honorary title of Mr. to the barbers of that era.
Huh.
And to this day, in the British medical system, when you graduate from medical school, you obviously receive the title of doctor.
Uh-huh.
But if you train as a surgeon, when you finish your training as a surgeon, there's actually a ceremony to appoint you the title of Mr.
Now that is new. I've not heard that before.
So as a cardiac surgeon, I'm always happy and proud to be called Mr. Yeah.
The fact that the barbers used to be almost like a doc in a box, right? Like people could go in with broken bones and even get some dental work done and stuff with the barbers.
Barbers were the basically the predecessors of the modern surgeons.
Right. Yeah.
Yeah. And the barbers were the doers. They were the ones that would try to fix whatever is wrong with you. The physicians were the intellectuals. They were the diagnosticians,
right,
and the researchers and things like that. There's always now in modern times a rivalry between the surgeons and the physicians.
uh-huh.
And
I wonder, did the term barber come from the fact that they used barbs to like bloodlet or something? That just occurred to me.
I don't know the origin of the term barber. We'll have to research that.
I'll have to. Yeah, I don't have an assistant here to like look it up for me, but
yeah.
I suddenly thought of that. That's interesting. Well, so you were a surgeon for a while. Let's just go to let's hear your history here. So you were a surgeon. I assume you still are, but are you still practicing surgeon or?
No, I have not operated for now 20 years. And I miss it terribly, but so I'll give you the quick and dirty background.
Cool.
Grew up as a kid in Cleveland, Ohio. Dreamed of being an astronaut someday, and there's the connection there with the rockets. And
actually, I was gonna test my nerd knowledge real quick. So you got a Redstone, Atlas, Titan, Saturn 1B, Saturn 5, and SLS.
Wow.
I have earned my stripes in nerddom.
All right. So
the Titan was always my favorite, actually. I just think it's a beautiful vehicle.
Then if you want to
And
keep going,
command module, and then a command lunar module, space shuttle.
yeah.
There's something else over there, but I can't make out what it is.
Oh no, that's just some awards.
Oh, okay.
And then
Oh, this is some
yeah.
awards.
Anyways, I'm impressed. I'm so impressed. So yeah, that's a whole nother story. But you met Charlie Duke last night from
Yeah, briefly. Yeah, that was really cool.
what a class act. And so uh, it's another tangent, but I sit on the board of trustees of something called the Astronaut Scholarship Foundation.
Right. Okay.
And
I was wondering how you knew him.
yeah. So I've been involved with that for quite some time. Haven't made it to space yet, but it's on my list. It's clearly now back in the category of must do instead of
Uh-huh.
dreaming about it. But
Okay, so would you rather go up on Virgin Galactic or Blue Origin?
only SpaceX.
Oh, okay. All right. So you want to go orbital.
Orbital is for me
Only way to go.
the true achievement of space flight.
Right. Yeah.
Yeah,
You're not legit until you get into orbit.
I won't use the legit.
You're like, let me back off of that a little bit.
I don't want to, but I would say you were. I will quote an astronaut that you and I spent time with yesterday, former astronaut, but he would ascribe an exciting plane ride to those first two.
Those suborbitals.
Yeah,
Yeah.
it's a little bit, it's when you look at Alan Shepard's first
Mhm.
flight in space, it was 110 nautical miles, and it was a 20-minute flight. He had 10 minutes of weightlessness, but you can achieve weightlessness just from a parabolic flight trajectory,
Yeah.
right? We actually have planes that fly parabolic. So the what are
Vomit
they?
comet.
Vomit comets, exactly.
Have you ever been on one?
I have not. I have been on a jet fighter, and I've done parabolic weightless trajectories on the jet fighter.
Okay.
Done barrel rolls. I had a blast.
That sounds like a vomit comet.
Yeah, it was definitely one of my top 10 adrenaline experiences.
Sure. I actually got invited to do I mean, they didn't call it the vomit comet, they called it zero wasn't there zero G anyway. There's a commercial company that does it outside of Vegas, I believe. And I got invited to do that for some National Geographic promotion or something. And I listened to the wrong people because they weren't paying for it. I mean, I didn't have to pay for it, but they weren't like paying me to do it. So I listened to somebody that was like, no, don't do it if they're not going to pay you. And I'm like, oh, okay. And then I didn't do it. And I've regretted it ever since because it was like, I've always wanted to do that. What was I thinking? So that was a really dumb decision on my part.
Well, if you're still interested, I can arrange that down. There's Charlie's doing one with a bunch of people from, we do these fundraisers, right, for the Astronaut Scholarship Foundation. So he's actually doing a zero G plane ride with a couple of the donors for the Astronaut Scholarship Foundation. At 86 years old. So pretty impressive.
Yeah.
But anyways, I grew up in Cleveland. Wanted to be an astronaut until I got glasses. And back in my day, you had to have perfect vision. And so it took me a year to get over my dream of being an astronaut, and figured if I couldn't be an astronaut, then maybe I'll be a heart surgeon. And went to
you have some pretty good ambitions there.
Went to my town doctor. It was a small town. There was one doctor, and he said, and I was in 7th grade, and he said, your timing is so perfect. We're starting this thing called a athletic trainer program for our football team, the high school football team. he said, if you're interested in being a doctor, I'll set you up in these graduate courses in sports medicine. It was a summer class. And I said, sure, that sounds great. So I took this summer class and I got to dissect cadavers and go to the operating room. And I was just sold that
Wow.
this is really, really exciting and fascinating. And so I knew I wanted to be a surgeon. Shortened my high school by 1 year, combined my junior and senior year of high school, and went to Ann Arbor, Michigan for college. And I've always been a gadget geek, and I was pretty entrepreneurial. So I even started I was into woodworking, and I started a little furniture making company when I was in junior high school. So I was always, we didn't have a lot of money, so I was always looking for ways to be able to buy a new bike and had a paper route, all that. So when I went to college, unfortunately, my first day of college, my father had a bad heart attack and died.
Oh, wow.
And so I was 17 and suddenly on my own financially, and had to figure out how to help support my mom and pay for school. And so I walked across the street from my dorm into the university hospital in Ann Arbor, knowing that I wanted to be a surgeon someday. I figured I'd get a job somewhere in that hospital, and walked up and down the halls to find anybody who might be willing to give some 17-year-old kid a job. And just remarkably, I was able to run into what unknowingly was one of the most prolific surgeon entrepreneurs of the 20th century.
Oh, wow.
And yeah, so I'll show you a little picture here. There was a guy by the name of Bob Bartlett.
Oh, you need to share your screen?
Do you want me to? I don't have
Is
to.
that what you're trying to do?
Yeah, I was, but I don't have to.
Well, I just need to give you permission real quick. There we go. Should be able to now.
Let's see. There we go. So there's a picture of me, 19 years old. And this guy invented a number of things. The most well-known is, well, there's several that are well-known, but the most dramatic is something called ECMO, which is a heart-lung bypass system that would rescue newborn babies who were essentially dying at the time of delivery from lung failure. And now that system called ECMO is universal therapy worldwide, has saved tens of millions of lives. And his original device is in the Smithsonian Institution. So I was really lucky to have a mentor and a second father, basically, who took me under his wing and was very inspiring and full of energy, and obviously allowed me to be able to have a job, to pay for school and so forth. And that's what got me, building new things and gadgets for healthcare. And my job was working in the intensive care unit around all of these monitors and technology. I mean, the ICU is the ultimate technology playground. It's got everything imaginable. And you learn all the physiology and all the medications. And so it was a very rapid immersion course in life and death decisions and monitoring, and I was just I was just all in. Worked 40 hours a week and went to school full time, and started publishing papers, and then got into medical school. Created my first company as an undergrad, and it was a guy who was an engineer. I'm not an engineer, but I had some really interesting ideas that all were derived out of the stuff I was doing in the intensive care unit.
Mm.
It was like, hey, we could build this, and found somebody to build it. And then we ended up licensing it to a medical device company, and got paid. I was like, whoa, this is good. This, pays for college and a sports car, and a few other things, and help support my mom. So it became this kind of thesis that I could be an entrepreneur, and pay the bills and do some cool stuff, and then go to medical school and be a doctor and be a surgeon. And so I had this parallel life
Mhm.
in clinical medicine and in business,
And one kind of informed the other.
yeah, it really did.
Yeah.
And I tell you, even to this day, when I just like on Monday, it was a lecture that I gave to a big audience of undergrads and grad students and medical students at Stanford, their health leadership seminar. And there's such power in having that clinical experience at the bedside and understanding the need,
Mm.
and then being able to go on the other side and find people that can build an idea that you might have for solving that need over on the clinical side.
Yeah.
So then I went to Duke to do my surgical residency, and trained as a general surgeon, trauma, critical care, cardiac surgery. And then I did thoracic oncology, which is basically lung cancer and esophageal cancer. And I did thoracic transplant, heart and lung transplants.
Mhm.
And
So was there anything being an actual doctor and surgeon that drove you to do more of the entrepreneurial things, like the gadgets that you were building? Like, was there,
oh,
were there just all these like human stories that made you be like, oh my God, we have to find a solution for this because this is ridiculous. People are dying for things that they don't need to be dying from, that kind of thing.
well, it was happening every day. And it was just so obvious to me, because we would do these big operations, and open somebody's chest and take a heart out and put a new one in, or a lung out and put a new one in, close them up, bring them into the intensive care unit. You'd have all these monitors and incredible data. It's the data that helps you see what's going on and be able to, keep them alive and get them better. And then they would get out of the intensive care unit and still have monitors and nurses. And then that magical day comes, sometimes only 5 days after their operation. And you'd walk into the room and it'd say, good news, it's time for dad to go home. And the family would go, what did he just say? You go, yeah, dad's ready to go home. And they go, not a chance. What do you mean? We'll go, oh, it's okay. We've got a list of things here. Just watch for this and this and this and this. And the family is just panicking.
Sure, yeah.
And yourself, the moment this person leaves the hospital, we're going to have no idea what's happening to them. Zero, none. And that's not good care, right? We just opened your chest 5 days ago. So every day that we sent somebody home, it was always, let's cross our fingers and hope that they do okay, because we're not going to know unless they show back up in the emergency room with a badass complication. And so this whole idea of, gosh, why can't we keep an eye on them once they leave the hospital? And so I started yet another company in 1998. And this was very, very early in the world of healthcare and technology. And it was using this thing called a Palm Pilot.
They were the thing for a while there.
They were, I mean, when you talk about digital health, and it became a buzz phrase, mobile health, health, right? Well, it all started with some of the things that we were doing on the Palm Pilot and making it possible for data to be captured on this handheld device. And in that time, you had a docking station, remember? And you'd then synchronize your Palm with your desktop computer. And then there's this really cool thing called the internet. And the internet was a place where you could send the data up to an application that could then be logged into by doctors and nurses to be able to see what's going on with hundreds and thousands of people who have a Palm Pilot. And wow, that was pretty earth-shaking. And we launched that company and did some really, really fun pioneering things with it.
So what I'm looking at here, it shows, okay, so that's something different, but the Palm Pilot, yeah. So it looks like almost like a calorie exercise tracker kind of thing. This isn't like something people wear. This isn't a wearable
Not yet.
tracking device. Yeah, you're not there yet.
Yeah, and so this was able to collect data that was entered. We were doing nutrition, and we had a system for diabetes and diabetes management of people that could keep track of their glucose and their nutrition intake and so forth, and then share that with their doctor, a nurse, or fitness trainer. And it was really the beginning of what we call connected care, remote monitoring, digital health. And then from that, we ended up developing again, this was before tablets and smartphones. So it was an internet appliance. And again, you could connect this device to your phone line, and it had a built-in 14.4 baud modem, and it would dial up the internet.
So you would get that going on.
Yeah. Yeah.
That was my impression of a modem for everybody listening. All the kids are like, what's that sound?
The 20-year journey of digital health.
Yeah.
So yeah, and this device would dial up the internet in the middle of the night, and it would identify the serial number of the device, which would be assigned to a particular individual. And then based on that individual, their condition, it would download a heart failure program or a diabetes program. And so when you got up in the morning, there was a set of questions waiting for you each morning. How do you feel today? And this was engineered by IDEO. Have you ever heard of IDEO?
I don't think so.
They're really, really well-known, quite revered engineering shop in Palo Alto. And they're famous for having engineered the first Macintosh mouse for Steve Jobs.
Oh, okay.
And it turns out they were also the design engineers for Donna Dubinsky and Jeff Hawkins in creating the first Palm Pilot. In fact, they were the ones that introduced me to Palm, and we ended up being the only company to ever have our own private labeled Palm Pilot.
Oh, cool.
So they engineered this so that it had a big display, at least for those days, and four buttons that you could hit with an arthritic knuckle.
Just make it as simple as possible.
Make it as simple as possible. And then it would ask you, 3 or 4 questions, and then that data would flow back up to a dashboard and allow a nurse to be able to see, 500 patients and red, yellow, green, because you could assign, if somebody said good, and do you have any swelling in your legs? No. Do you have any shortness of breath? No. Are you taking your medications? Yes. Those answers would all get categorized green. So if somebody was all green, they don't need my attention today. So you could have a dashboard, what we call exception management, and be able to have one nurse monitoring 500 people all the same day, because you already know which ones are having a problem versus which ones aren't. And then there's probably 20 who might need some attention. So that's where you could spend your time on a phone call, and be much smarter about that precious resource that's that healthcare professional. So, when we talk about, where healthcare is going, it's not an either or proposition. It's really an opportunity to use technology to be able to, with a wearable sensor, be able to capture this really rich data without any effort on the part of the patient, what we call passive monitoring. And it has to be medical grade, FDA in our country, because we're going to be making really sometimes life and death decisions. But then all that data can flow back into a dashboard and allow for those exception management decisions to be made. And then, you can do what we call care traffic control and have basically closer, better monitoring of someone in any setting, whether it's in the hospital or at home. And this is really all about delivering care, into the home rather than you having to go to care.
Yeah.
And now, just last week, a McKinsey report came out and concluded that $265 billion worth of healthcare is going to be moving from the hospital to the home setting just in the next 3 years. And it's all because of this capability with a wearable medical grade sensors such as ours.
Hey, Joe here. So I hope you're enjoying this chat with James Mault. I know there was some mind-blowing stuff to me anyway, but then again, I'm interested in this kind of stuff, which is why when I was given the opportunity to produce an original series for Nebula, I went and looked at the human body. And because I'm a little bit of a freak, I went with the weird stuff. And that is how my series, Mysteries of the Human Body, was born. I was curious, what are the rarest and weirdest diseases of all time? And the flip side to that, why are there some diseases that are super common, but for some reason we still can't cure? I wondered about famous human oddities and what made them that way, and weird plagues throughout history, and why we age the way we do. So I made some videos on those things, and now they're all on Nebula. That, along with all the videos from my YouTube channel that are ad-free, right alongside with tons of other amazing educational YouTubers that I've been fans of for years. And I gotta say, it's a nice little feather in my cap, honestly, to have my stuff up there alongside these people. Nebula is basically a curated list of some of the most awesome, smart YouTube content, free of any algorithms or advertising. And you can get free access to Nebula when you sign up for CuriosityStream. If you haven't checked out CuriosityStream by now, it's the streaming service for curious minds, which is why I imagine if you're listening to this, you are right up there with the CuriosityStream audience. It's got to be your thing, right? CuriosityStream has thousands of documentary films from some of the best filmmakers from all around the world on just about any topic you might have interest in: science, art, engineering, history, and yes, healthcare. So if you enjoy exploring the cutting edge of the future of healthcare like we're talking about here today, there's an excellent episode of the Dream the Future series, narrated by Sigourney Weaver, on the medicine of the future, where they talk about advancements in medicine and how these advancements will shape the way we live in the year 2050. So if any of that sounds interesting to you, the good news is you can get both of these amazing platforms for only $14.79. That is for an entire year for 2 streaming services, which is just bonkers. I still can't believe it's such a good deal. I did the math. It's like 62 cents per month per streaming service. So unless you can find a service that actually pays you to watch it, I don't think you're going to find a better deal out there. So yeah, to get all that, just go to curiositystream.com/JoeScottPod. Again, that's curiositystream.com/JoeScottPod, and you can start the process of wondering why you waited so long to sign up for this in the first place, which is going to happen, I promise. So one more time, it's curiositystream.com/JoeScottPod. Go check it out, and thanks to CuriosityStream for supporting this podcast. Now back to Jim. We got there. Okay. So there's actually 2 different of these, right? So there's this one, and then there's one that has like 2, like there's like a little...
call it a dumbbell.
Okay, yeah, that makes sense.
Yeah.
So what's the difference between these 2?
Yeah, so we started with the BioSticker, and stickers are kind of, we grow up with them. They're friendly, they're non-threatening. Sometimes we get in trouble if we put them on the wall when we're a kid. But it's sort of like a Band-Aid, a 3-year-old to an 83-year-old. That's not much effort, and it doesn't take a lot of training. So we wanted to get to a place where it was as simple as what we call stick it on and forget it.
Sure.
And so the first device, the BioSticker, has a bigger battery, basically. So the battery compartment on one end, and then all the sensors are on the other end. And so this is measuring temperature and heart rate and respiratory rate and body position and step strength and all sorts of cool stuff. There's some big advantages to being on the chest versus out on the wrist.
Yeah.
Out on the wrist is not where you reliably measure somebody's body temperature, or frankly, even analyzing their gait. You can't tell if I'm walking or sitting, or you can't tell if I took a step with my left leg versus my right leg. But we can, because we're on the vertical axis of the human body, so we can actually see when you take a step to the left and to the right.
Okay. So you can like measure people's gaits a little bit as they're walking?
Literally, yeah. We can actually measure what's called the gait symmetry. So we can see if somebody has a bad right hip or a bad left knee. And if they have knee surgery, we can see them hopefully getting better over time because their gait gets stronger and their cadence. So it's really cool. We're able to measure stuff in a very accurate way that's never been measured before. So the BioSticker essentially has more battery power to be able to make very high frequency measurements. But it's a little bit bigger, right? It's not terribly big, but we got to a place where we needed to have something that was smaller, sleeker, thinner. Mm-hmm. And, by doing so, it has a little bit smaller battery. So it's still making all the same measurements. They both last for 30 days, but the BioSticker is measuring heart rate and respiratory rate every minute. This is measuring heart rate and respiratory rate every 15 minutes, which is still really frequent.
Sure.
But it's not as statistically high frequency as the BioSticker.
Okay.
So that's about it. And the other difference is this is a single-use disposable. So when you start talking about medical stuff, for better or worse, in the United States in particular, hospitals like to just throw stuff away. But the good news is this guy is more environmentally appealing because we actually recycle these, and in an environment of a chip shortage right now, it's nice to be able to recycle those chips clean it, put a new battery in, and send it back out.
So these, are they not recyclable or rechargeable?
No, that one is not.
Oh,
We
okay.
do have, we haven't announced it yet, but
Ooh, an exclusive.
an exclusive. There is a
Ooh,
rechargeable version of the Bio button that is about to be announced.
cool. Cool.
Yeah. So
Um, okay, so there seems to be two different use cases for this, and I'd like to hear you talk about both of them a little bit. But like, there's the medical one where you've been released from the hospital, and doctors can kind of monitor you and keep track of you. And the other one, I guess, is just for like personal monitoring, and you can sync it up with your phone and keep track of stuff. Like, how would you describe that second use case, like the personal one? Like, what's the benefit of that?
yeah, so it's kind of this very big spectrum. So we'll start over here on the what we call the high acuity. Turns out we have FDA clearance for in-hospital monitoring, and this is a very, very vivid scenario right now because there's a workforce shortage,
Yeah.
especially for nurses. A lot of them are burned out from COVID. And so it's getting very, very expensive to find nurses, and the salaries have gone way up. So right now, there's a Wall Street Journal article just a few days ago. The average cost for a traveling nurse staffing services is over $4,000 per week for a staff nurse. And so, typically outside of the intensive care unit, if you're in a hospital bed, the nurse is coming around and taking a set of vital signs, maybe at the most every 4 hours, but typically it's every 6 hours. Sometimes it's spread out to every 8 hours. So at the most, you're getting 6 measurements per day as a patient. It might be 4 or it might be 3. And that's, if the nurse is doing that on 20 patients, that's kind of a busy day.
Yeah.
So you're talking about $1,000 to take vital signs 6 times on 20 patients. This sticker is measuring those vital signs 1,440 times per day for $2 per day.
Wow.
So we have a whole lot of hospitals very interested in putting a sticker on people as they're coming into the hospital or even in the emergency room. And when you think about it, because of the data frequency, 1,440 measurements per day of temperature, of heart rate, of respiratory rate, we're able to apply these analytics tools, and we can see what's happening to these patients, which with much higher resolution.
Mm-hmm.
It's like having a 4K movie of a patient versus 6 snapshots, right? It's a good analogy.
Yeah, yeah.
And so it's kind of better care for more people at a fraction of the cost. And so that's on the inpatient side. And then what's cool is we can watch and say, hey, we got so much high frequency data. It's pretty obvious this patient is really stable. You probably don't need to be laying in a hospital bed, send them home.
Mm.
And so you're starting to see an opportunity because of the data. We can be smarter about when to send somebody home, and you send them home with the same sticker. So because again, it's very rational. If you have no way of monitoring somebody after they leave the hospital, then you have to keep them longer because you're worried that something bad is going to happen if you send them home too soon.
Yeah.
And you have no way of keeping an eye on them. So now this lets you off the hook essentially, and the families as well, because when you go to a family, you say, hey, it's time to take dad home. The family goes, what?
Right.
can't dad stay another day? Because we don't want to be responsible for something going bad.
Yeah,
So
they're looking at all the machines and being like, I've got to be all those machines now. And I don't
yeah,
know how to operate all that. Yeah.
yeah, and it's a big burden on the family. So you're going to see it becoming much easier. These boundaries are going to kind of fade away, and the being in the hospital versus discharge. It's like this word discharge. It's kind of an unpleasant term. You know, you've been discharged. Go away. We're
Yeah.
done
Yeah.
with. Right.
Or your body produces a discharge. That's not good either. It's
Yeah.
all kinds of bad references there.
Yeah. So now the hospital doesn't have to talk about discharge. The hospital can talk about, we're going to take great care of you no matter where you need to be. And it's going to become more and more, we're just going to take good care of you in your own home, because we're just going to give you one of these stickers. And if we see something starting to something brewing, we can send a nurse to your house cheaper than you laying in the hospital bed.
Yeah.
Or we can see it coming early enough that we can say, okay, go see your doctor, right? But don't go to the emergency room, because that's unnecessary, because it's not a crisis yet. We want to be able to see this stuff before it's an emergency.
Right. Yeah.
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 And that's why this is so exciting.
Yeah.
And so this applies to so many things. When you go home from surgery, you're going to go home with a sticker. Whether you had a knee operation, we'll be able to see that you're walking better and your gait is better. If you're a cancer patient, we talked about it. You're going to be able to see somebody developing a fever. If you're a heart patient, we can monitor your heart. But then we start talking about, just employer wellness programs, and a lot of companies spend a significant amount of money on these health risk assessments or screening programs. We do a once a year screening program. Even when you go to see your doctor for an annual visit, your doctor's going to have, if you're lucky, 20 minutes with you. That's not a lot of time to be able to see some subtle things that are going on. So what's going to happen is you're going to get a sticker in the mail a month before your doctor's visit, and you'll wear it for 2 weeks. And then there's this 20-page report that's going to get a printout. You'll get a copy and your doctor will get a copy. And now it's sort of like, I love this analogy. We all have cars, and now when you take it to the dealer, to the shop to get your car, maintenance, what does the mechanic do? Well, they plug it into the computer and they run a 78-point analysis. And so right here, ma'am, it looks like your alternator is going to fail in a couple of months, so we should replace that. So now you'll go into your doctor's office, and your doctor will have this printout of how you breathe, how your heart's working, how you're moving, how you're sleeping, how you're walking, and be able to say, you know what, we're starting to see some early issues here.
Yeah.
You're
the second person that I've heard make the car analogy, and it's so apt, because like we spend far more time and effort and thought into maintaining our cars than we do ourselves.
It's sad.
Yeah.
It's true.
And we have a dashboard with a little light that comes on when there's something wrong. We don't really have anything like that. I guess that's what this is attempting to be. So
that's exactly right.
Yeah.
And it's also, in a serious way, part of the problem when you say we don't do that for ourselves, but we do it for our car. Part of it is because we make healthcare inaccessible. It's complicated. The whole system sucks. and it's expensive to see your doctor and then get your insurance to pay for it. So there's a lot of disparities in access to healthcare and the cost. This is kind of the universal, leveling the playing field. So we can make it very easy for everyone to have really high quality care at a low cost.
Mhm.
And I think you're going to see this remote monitoring and medical grade wearables are going to be a very important democratization of healthcare, and it's pretty exciting to be at the front of this.
Yeah, that's cool. You mentioned insurance companies a second ago. I was curious how, um, having something like this that you can wear, whether you just got out of the hospital or not, how that would impact insurance rates. Like if,
Oh, well, it's, I mean, again, you can go back to the automotive analogy. If you get in your car and you're willing to have a sensor in your car that shows your ability to, drive safely, and you're not speeding and you're not braking hard, and there's this self-braking sensor, so it'll keep the car from crashing it. The auto insurance costs have gone down. Now, have they reduced the premiums? They're probably keeping a lot of that money, but we know that with self-braking cars, the number of auto accidents is definitively going down. So when it comes to healthcare, the more we're and actually this is very vivid. Medicare itself, the federal government, which now, as an aside, is paying 50% of all healthcare expenditures in the United States are covered by Medicare. So the government is now the largest insurance payer. There's the commercial payers, but it's now 50-50. So the government started reimbursing for our stickers and remote patient monitoring last year, and to the tune of the potential eligible reimbursable population right now amounts to over $30 billion of opportunity, if you will, for patients to get monitoring paid for by Medicare. So the insurance companies are quickly figuring out that this kind of thing will help keep people out of the emergency room,
keep the costs down. Yeah.
And that lowers costs. And then if we can get people out of the hospital sooner and safer, that lowers costs. And this also allows you to keep monitoring somebody after they've left the hospital so that they don't boomerang back. It's called a readmission. So all of those are hundreds of billions of dollars of costs that, if you say we'll spend 30 billion on this and we'll save 100 billion on ER visits and readmissions, the ROI is a no-brainer.
Yeah, that's wild.
So the commercial payers are figuring this out as well, and they're starting to reimburse for remote monitoring.
Yeah.
I mean, it'll get to a place very quickly where, when your kid has a sore throat and a fever, the last thing you want to do is take your kid to the pediatrician sitting in a waiting room with 20 other sick kids.
Yeah, coughing and sneezing.
Because if your kid's not sick, you're going to create a nice opportunity for them to get.
They're about to be, yeah.
They're about to be. So, the future state, which is only probably 2 or 3 years from now, mom's just going to have a sticker in the pantry, and when anyone in the family feels sick, you throw on the sticker, and then that data is going to go to a nurse case manager and your doctor. They'll get paid to keep an eye on you remotely. You don't have to get in a car and sit in a waiting room, and and they're delivering great care.
Mm-hmm.
Yeah. No,
This is awesome. I just think this is really cool because the older I've gotten, the more I've been, I guess, cognizant that like the earlier you fix a problem, the less problem it becomes, and the easier it is, and the less expensive it is, health wise or anything else for that matter. So this is really cool. Okay, so just we're starting to get a little short on time, so I want to kind of get this out there. So it monitors heart rate, blood pressure.
Hold that thought.
Okay. All right. Okay. Steps. So maybe calories burned kind of thing.
So I'll give you the whole list. So
Yeah. Let's hear the list.
temperature,
Okay, yeah.
which is a key measurement for all sorts of reasons. Heart rate, respiratory rate, and the respiratory rate one is interesting. That's hard. Most nurses don't really measure respiratory rate even in the hospital because it's pretty subtle to see each time you take a breath, even sitting here on the camera. And so nurses and doctors,
I'm all aware of it now.
we're all guilty of it, but we tend to write down 16, 16, 14. So this is actually measuring with ridiculous accuracy every minute. So,
Okay.
so for the first time, we've got respiratory rate as a reliable clinical measurement. And then we are also measuring, we know your body position. So again, unlike a wrist wearable, we always know what's front, what's back, what's left, what's right, what's up and what's down, because this is stuck to your anterior chest wall, and we know the skin side. So what's cool is every minute we can tell if you're sitting up, or we can tell if you're laying down. If you're laying down, we can tell if you're laying on your back or on your stomach, on your right side or left side. We can tell if you're sleeping at an incline, which unfortunately, when people develop heart failure or breathing problems, they tend to sleep on a stack of pillows because it's hard to breathe when they're laying flat. So with that, then we're also able, as we talked about, to measure the symmetry of each step that you take. We're able to measure the strength, the forward exertional effort from the left leg and then the right leg, and then the left leg and the right leg. So we can actually quantify step strength. And, it doesn't sound that interesting until you realize, people on chemotherapy are losing muscle mass. And so if you see their step strength going down, they're headed for trouble. If you see someone who's had a hip replacement, you want to see their step strength getting better over time. There's all this beautiful, again, we have the benefit of a 4K movie. We have this longitudinal view rather than a single snapshot of information. And so we can watch what's happening, what's the trend. In many cases, the trend is more important than the absolute value.
It's amazing how much you can infer from a small set of, well, I don't want to say a small data set because it's not a small data set, but like a few different parameters,
Well, yeah, that's the other beauty of this, is so many things have been what we call one-dimensional. We have this what I would call a composite picture. When you have an infection, your temperature goes up, but there's you might have gotten in the shower. That doesn't mean your temperature went up, right? Doesn't mean you have an infection. So we also have heart rate. Well, if you really have an infection, your temperature goes up, but your heart rate goes up with it. And actually, you have to breathe faster when you're infected. So we have this cross-sectional composite picture to be able to see multiple independent variables that correlate to a particular circumstance. And that's where the real power of AI, people overuse that word, but we're kind of a two-headed beast because we have all this cool wearable sensor hardware, but in our cloud, we're actually watching all this rich signal, multiple parameters, and the trending of these composite pictures. So it's a really, really exciting time in healthcare, and what we call we're going to be moving healthcare into a practice of intelligent care, because we haven't been very smart about healthcare over the past 100 years, to be honest with you.
It's more like sick care.
It's sick care. Yeah. And I mean, the other sad statistic is our healthcare system itself. I don't know if you know this number. The third leading cause of death of an American citizen is our own healthcare system. Because we actually make a lot of mistakes, and it's underreported. We know that it's at least 700,000 people per year die from mistakes and errors that we make, but there's even more deaths because we're just too stupid to realize what's happening until it's too late, right? We don't have good data, or the data that we have, we're not able to process it in order to see what's coming until it's too late.
Yeah. Well, that's a sobering thought.
No, but the cool thing is this changes everything, because now you have real data that's high frequency, multiple parameters, and the cloud can actually process. I mean, here's another statistic. In the intensive care unit in the operating room, all of those monitors are generating about 1 million pieces of data per hour. 1 million per hour. What human, doctor, nurse, or anyone could make sense of 1 million different pieces of information in an hour? Not a chance.
Right.
So the most we can do is glance up at that number and that number, that number. In fact, the Institute of Medicine published a paper concluding that the most, from a cognitive capacity perspective, the amount of data that can be consumed and assimilated in order to make a decision is about 7 pieces of data. 7
for a human.
To take into account to make a decision, whether it's driving a car or anything, right? Think about all the stuff going on. Could you take into account 7 different things in order to make a decision about stopping or swerving or your surroundings? I mean, and so when you think about medical information, there's no way you can make sense of 1 million pieces of data, but the computer can. Computer can watch all that stuff, and it can run these algorithms in milliseconds and then say, hey, idiot, do this. And frankly, that's what our smart cars are doing. The cars are watching all these sensors and the speed of who's in front of me, what's nearby. And if it sees a scenario that's a potential crash, it will apply the brakes faster than human response time could figure it out and hit those brakes.
That's a whole topic right there. Whether or not and when computers will drive better than we can. I think just their ability to see everything all at once gives them a huge leg up on us.
Well, we've already shown in medicine. This project, I think, started around 2013, and they were comparing mammography, breast for breast tumors, the computer reading the mammogram versus the radiologist. And in 2013, the radiologist was better. 2014, the radiologist was better. 2015, 16, 17, 2018, the computer was better. And that's what's happening now. The AI and the computer algorithms are now becoming better at finding a breast tumor than the radiologist. So I think you're going to see a lot of this type of thing happening.
Yeah.
Now you still need the radiologist, sort of like in the cockpit of a commercial jet. The autopilot is flying that plane, but you still want a couple of pilots in there just in case. Sort of like the what is the name? Sully? Yeah.
Sullenberger.
Whatever
his first name was, I forgot already.
But yeah, he made a brilliant decision in split seconds. The autopilot would have crashed that plane, but he was smart enough to use good judgment and land that thing in the Hudson.
Yeah.
And so it's not an either or proposition, but all of these systems are going to make us better and smarter, I think, especially in healthcare.
Well, cool, Jim. I appreciate your time, and this is just super cool. And I'm curious where these things are going to go in the future. You're already working on the next generation of it, like.
Oh yeah.
Do you ever see one just being implanted, like inside, that can monitor like stuff in the blood and whatnot?
People that have pacemakers and defibrillators, it's actually collecting a lot of this data without them realizing it.
Oh, okay.
I think people are really excited about the fact that we can get all of that data without implanting.
Yeah.
It's kind of the other way around. I like a lot of other people would be pretty nervous about something being implanted unless you really, really needed it.
Sure,
right?
Sure. That's kind of the point with the AI and everything, is it can infer all that stuff from what you can get on the outside. That makes sense.
Yeah. And you can take it off when you don't want that data. I mean, truth is, this can see when you're breathing fast and your heart's beating fast, and we know your body position, so we can see.
When you're having sexy time, we can monitor that.
There you go. See what kind of lover you are.
Yeah. Well, on that note, this has been a lot of fun, man. I really appreciate it. Is there any place that people could go to learn more about this? Or, I mean, this isn't something people can just go buy. This is more of like something their doctor gives them, right?
Right now, it's primarily direct. It's through your doctor and hospital. We did actually have some direct consumer programs. We had countries that required, during the hard pre-vaccine days of COVID, you had to go online and purchase our sticker and wear it for 7 days, and then we would actually generate a report that went to, like, for St. Lucia. To go to St. Lucia, you had to wear a sticker. So we can see if you're having early signs of an infection. So we have had some direct consumer programs, and it's likely you'll see this becoming available at your local pharmacy and other places, sometime hopefully later this year.
Okay. Oh, cool. I look
but
forward
you
to
can
that.
go to biointellisense.com and tell your doctor, this is what you want for you or your family.
Hook me up. Give me the sticker.
You got it.
All right. Well, I'll let you go. Thanks a lot again. And I look forward to seeing you in the near future, right? In April?
Yes.
Yeah.
Yes.
But we'll have some fun.
Good. Love it.
All right. Big thanks to Jim Mault for sharing his time with me. He and his team at BioIntelliSense are doing some groundbreaking work, and I think it's just super interesting where all this is going and what the future is going to look like because of all this. If you want to learn more about what they're doing, you can find them at biointellisense.com. This episode was produced by Kimmy Britt, edited by Bray Brown. I'm Joe Scott. You can find me at Answers with Joe pretty much everywhere on the socials. Of course, my YouTube channel is Answers with Joe. Anyway, thanks a lot for listening. Please do share this if you thought it was interesting, and a nice review on whatever podcast player you're using right now really does go a long way. But until next time, have a good one. Go out there and start some conversations of your own. Take care.